It's a very important point. I mean, I think childhood ALL has really led the field of hematologic malignancies in general in showing that firstly MRD is a key determinant of likely treatment failure or response, and that it is of the equal or perhaps more important than almost any other risk factor, genetic or otherwise, for predicting outcome. And the second observation based on that is that one can tailor the intensity of therapy according to treatment response and intensify or de-intensify therapy and improve good outcomes. And in particular, some of the studies at St Jude Children's Research Hospital in ALL have shown that this risk-adapted therapy, and that centre was really the pioneer for this in ALL, can be used to override some of the historic poor outcomes associated with high-risk subtypes of leukemia. So with all that being said, I think a couple of implications are people are now seeing the importance of MRD monitoring more generally in ALL, in adult ALL, as a predictive risk factor for responses to immunotherapy, for transplantation and more intensive treatment approaches. The other area in which MRD monitoring is changing is the use of more sophisticated approaches to measure MRD. And so historically the approaches have been immunophenotyping or flow cytometry, counting the numbers of cells by flow, or focused genetic approaches, for example, looking at antigen receptor gene rearrangements by PCR. And now as we see the field moving to sequencing-based approaches in ALL, the same are being applied to MRD monitoring. And there have been some very important studies recently showing that firstly, sequencing-based MRD monitoring is feasible, and secondly, showing that it can actually discern groups of patients that might be apparently MRD negative by conventional approaches, but positive by sequencing-based approaches that may also be at risk of an adverse treatment outcome. So I think as we move forward, the field will be more extensively using these next generation MRD monitoring approaches, as well as extending them even further and looking at mutation-specific MRD detection approaches as well. We've seen some of this emerging in AML, looking at the presence of mutations at initial remission as a predictor of outcome, and the same is now being explored in ALL as well. We know that there are certain mutations that are enriched at relapse in ALL that are associated with resistance to therapy, sometimes resistance to specific drugs. And so I think we'll see more activity in trying to identify these relapse-driving mutations at early time points in therapy, even at diagnosis.